Morning everyone. After a couple of weeks with microphone problems, looks as if everything's good. Morning Steph. Good morning. Right, let's get going. So last week we were looking at the kind of gross musculature of the shoulder, mainly the shoulder girdle muscles and then some additional ones as well. Kind of split it into anterior, posterior and lateral muscles, and we covered all of those. So now it's time to get into the rotator cuff. So here we go. Let's have a look at this. Just grab everything ready. All right then, so I teach this as if you've never really heard of anything before, not really sure where anything is. So if you do know stuff, apologies, but sometimes it's nice to go over some of the basics again. So the rotator cuff then. It is a bunch of muscles that surround the humeral head. Morning, Tristan. And they are tasked with, amongst other things, just disconnect this from its base, to keep this humeral head in close proximity to the glenoid, which we've been talking about over the last few weeks. Okay, so we've got 4 muscles that are implicated in the rotator cuff, and they are often blamed for a lot of problems. So we're going to talk about that as well today. And there's some kind of myths that have been around for a long time about what the rotator cuff do and the kind of actions that they have. So if you read a lot of the textbooks, you'll see those myths perpetuated, and we'll discuss some of them today and just get you thinking a little bit, because I think there's elements of truth in everything, but then I think some things are said with such certainty, like this does this and this does this, and it's not that simple, and we've discussed that with other things as we've gone through the rest of the body as well. So we've got the rotator cuff's job then, so keeping the humeral head within the joint as a counteracting or work it as antagonistic group to the deltoid. Attaches the scapula to the humerus, definitely does that. So there's lots of the very broad attachments on the shoulder blade, the scapula, and then some quite specific ones on the humeral head where they attach. We've got 4 muscles altogether, and I think that one of the reasons why I've kind of stripped things back the way that I have around the shoulder is if you do it in sections, then it's easier to remember, because there's lots going on in the shoulder, and there's lots of attachments to remember and lots of bits crossing over each other. So if you do break it down into front of the shoulder, back of the shoulder, side of the shoulder, and then the cuff, I think that makes it a bit easier to kind of get to know everything, basically. Morning, Imi. Good to see you in as well. So yeah, we've got 4 muscles surrounding the joint, and they blend in with the glenohumeral joint capsule. So we've seen the capsule a couple of weeks ago, and we're going to start adding in the muscle layers now, and you'll see how everything just merges in together, and why it's often quite, especially if you haven't had any imaging or anything like that done, you're doing some tests on the shoulder, some clinical tests, and you go, oh yeah, this test is for this muscle, this test is for that muscle. It just doesn't work like that, and we'll just kind of discuss that as we go, because everything's all joined in together. They form a cuff around the joint. The cuff is at its weakest point is the anterior inferior area. So towards the front and then down. Okay, so that's and that makes sense, because if you have a look where the muscles are, they are, well, there's three of them around the back here. One of them superiorly, another one at the front, and of course they can't attach inferiorly. Well, they could, but it would block a lot of movements, because you need the free space underneath the humeral head, so that you can move your arm about. Okay, so it's yeah, it's pretty obvious that this is going to be the weakest area. Most common direction for dislocations is in that direction, and it's because there's nothing there really to stop it other than the capsule. So if the arm's in that kind of up position and then gets forced downwards, it's not like the hip joint where the socket's really deep, and there's a bony restriction for those types of movements. It's not like that at all. It's where you've seen the glenoid, kind of like that, and then the humeral head just kind of floats on it. So it's it doesn't engulf it like it does in the hip. So it's understandable, really. But we sacrifice stability in the shoulder for mobility, so that we can move our arm around. So the first one we're going to have a look at is this one, and the names of them, again, apologies if you know this already, but for those of you that don't, never really heard of the rotator cuff before, so this muscle here sits, if you remember from a few weeks ago, we were looking at the bony landmarks of the shoulder. That bit there is the spine of the scapula, and then it turns into the acromion, which is this bit just here, and the spine of the scapula is the dividing line between two of the rotator cuff muscles. One of them is superior to the spine, one of them is inferior to the spine. So superior to the spine is this one, which is supraspinatus, spinatus, whatever you want to call it. And then the one below it, which fills this space here, is inferior. So infraspinatus, again, however you want to pronounce it. So we this dividing elevated area, so this elevated area of bone, gives these two muscles their name. So superior to the spine and inferior to the spine. So that will help you with remembering them if you're doing an exam, or just an examination of a patient. But it will also help you identify where they are as well, because if you can feel that ridge, that spine of the scapula, so along here, and then you roll above it or below it, then those muscles are going to be in that vicinity. There are other muscles that overlay these, so they're deep to some other structures as well. But yeah, you will be over those muscles, not directly, but they will be underneath your hands. So supraspinatus is in the supraspinous fossa. So a fossa is a dip or a shallow in the bone, and that's yeah, that's just the name of a dip. Okay, so that's what it's giving that name. Morning, Jules. Morning, Claire. I haven't seen you for ages, Jules. Good to see you back. And then we've got the greater tubercle of the humerus. So there are two big lumps on the humeral head. Let me just switch my cameras a sec. Let's go back to this one. So here's your humeral head. This is the front part. There's your coracoid process just there. And then just on the side, we've got two big bony lumps. Well, one's bigger than the other. So this one here is the greater tubercle. And then can you see that there? That little bit of wire there, that's representing the bicep tendon. And then just in front of that is the lesser tubercle. So we've got a big one and a little one. And this muscle that's popping through here, that's the footprint, the attachment point of the supraspinatus. There it is there. Okay, so it attaches onto that point there. Obviously, it doesn't move in real life, but we can have a look underneath it. So you see the bicep tendon runs underneath this one, and then it attaches onto there. Morning, Mo. So we've got the, just give you a bit of an orientation again. So there's the acromion. There's your acromioclavicular joint just there. There's your clavicle. Okay, so the supraspinatus, which come around that way probably. So there's the spine of the scapula just there. There's the acromion as it comes around, and then there's the supra just there. So if I turn it that way, you can see it disappears underneath the end of the clavicle and underneath the acromion. just there, and then pops out here. Okay. Now, this kind of space here, this subacromial space, there is a bursa in there as well, which we talked about last week. And it's been that this region has been, switch on to the other one, has been blamed for a lot of problems. Have I got it here? Yeah. And I'm not one to swear, especially doing stuff live. But I've nicked this off a guy. Well, I haven't nicked it. I really like it. So yeah, I will promote it. Let's say for a guy who does swear quite a bit. And this is Adam Meekins, and he talks about the special tests for the shoulder. And there's lots of clinical tests that you can do where you move your arm around and basically you're trying to pinch these structures underneath the acromion, and then it's called a shoulder impingement. And then years ago, if the solution was surgery, because if something's getting pinched, then we need to clear some space out. And now we know that that's not really the case, that if you just leave it alone, then often it's as good as having surgery. So, and the outcomes after, sort of a year, 18 months are exactly the same. Okay, so you may as well just leave it alone. And basically those special tests, they're not very specific because there are so many structures there. So basically something hurts in the shoulder, which is the shits bit. Okay. And I've always kind of said that on the courses that I teach, that you've basically got hurty shoulder. Yeah. So it's I'm a bit more eloquent than that with in front of patients. I don't think they would appreciate that kind of I don't know. It's kind of like you're joking about it, okay? Because obviously they're in a lot of discomfort. So we could name a whole bunch of structures that are in that area to kind of validate the reason why they have symptoms. But really, we don't fully know which one is the problem. Okay, so we don't know what is causing the symptoms specifically. We just know that something hurts in the shoulder. So then the exercises, they go, well, what exercise is good for this? What exercise is good for that? There aren't any exercises that are specific, again, for specific structures in the shoulder. So this is where the giggles comes in. So get it going, get loading, and evade scans. Because if you scan it, then it's likely to have some kind of, depending on your age, some kind of pathology. There'd be some kind of tear, or there'll be a bit of swelling or whatever. And often we blame the imaging findings for the pain. But if you scan someone without any symptoms, they also have these imaging findings as well. So again, it's a bit blurred with the scans. So and often as well, if you say, oh yeah, you've got a tear in the muscle, then people will be scared to use it. But so we need to be careful of giving that information. And I'm not sure who this person is as well, but I think Adam took the giggles bit from this person here. I need to find out who they are. But basically, yep, it's something hurts in the shoulder, get it going, get loading it, and evade scans. And I think one of the good things, especially when you're seeing someone who's in discomfort with this kind of in this area, is it's not if you do a strength test and something hurts, it's going to test weak, and it's not because it's weak, it's because it hurts. So if you could take the pain away and test it, it will probably test fairly strong. So if you do some treatment to it and then 45 minutes later you test it and it's strong, you can't say you've got it stronger, because that's not how strength works. So you can't get stronger in 45 minutes. What you've done is you've adapted their pain tolerance, or you've adapted their tolerance to load. And that's what the goal is in these, if you have someone who's coming in and they've got a sore shoulder. So we're not trying to get it stronger, we're just trying to get it moving, get it going, get it loaded, but without any trying to minimize discomfort, basically. And one of the things, the reason why I say all that is because one of the things that supraspinatus was purported to do was initiate the first, I think it was 20 degrees, we used to say, of abduction. So bringing the arm up out to the side. And when it's been tested and they've done some EMG on the muscles around the shoulder, every single muscle around the shoulder is engaged in shoulder abduction. So it's not just supraspinatus. It would make sense that it could be, because of where it is, where it attaches, the direction of the fibers and the action. But you also need all of the other muscles to work alongside supraspinatus so that you can bring about shoulder abduction. Because if you have a complete tear in supraspinatus, you can still abduct your shoulder. So how is it an initiator of abduction if, when you've completely torn it, you can still abduct your arm? Yeah. So again, those absolute statements, I'm starting to challenge those now. So I just wanted to bring that in on this first one, the first muscle. Let's have a look at it and see what it looks like. So here is supraspinatus. So all of your anatomy from before, the picture that we've just seen as well, and then this is it for real. So if we have a look at some of the structures, and again, if you come to the labs, the anatomy labs, and we talk to anatomists about these structures, and what you'll see is that a lot of the bodies that are donated are people that are in their 80s or 90s. So there's a lot of changes to the joints. There's a lot of arthritic changes. Some of the muscles are very small, and the anatomists will talk to the students, and I have to have a bit of a word to the students about it afterwards, because they will say, oh yeah, these changes would have been painful, and that's not necessarily the case. Okay, I'm not sure the age of the specimen on this one. The musculature is pretty good, so I wouldn't imagine they were in their 80s. But yeah, we've got to be careful with kind of looking at, well, a dead body or an image, and looking at the structure and saying that's the reason for your pain. Sometimes it can be a contributing factor, but sometimes it's not. So there's the spine of your scapula. There's the acromion just there, and then there's the supraspinatus just above it. So your supraspinous fossa, that region there, so it starts in the fossa, goes underneath the acromion, and then onto that greater tubercle just there. Okay, so if we have a look from this side view, there we go. So there's the subacromial space, and this was the space where we used to think where all the problems were, and you'd have to have decompression surgery and all that kind of stuff to, or shave bits from underneath. Sometimes that is beneficial, but sometimes it's just not needed, and we can crack on with rehab. We can get it moving, get it going, calm it down, build it back up again, and they don't need surgery. Okay, so it's but it can be it's really debilitating when you can't use your shoulders. So you get really annoyed with it, and you just want a solution. And sometimes people are hell bent on having surgery. There's the space just there. So obviously there's usually a bursa under there, but in a cadaveric model you don't see bursas because they're dried out. And yeah, so this was the paper that I was talking about before. Does supraspinatus initiate shoulder abduction? So that's a really nice paper to have a look at. The text is so small for me. 2012, I think it was. Yeah, 2012 there. So it's not new information. Yeah, this is information that's been going around for like 13 years. So it should be pretty mainstream now, and that this kind of stuff shouldn't really be continued to be taught. But there we go. What we've got here as well is a very, very simplified way of learning the action of the rotator cuff muscles as well. This is often useful for exams, but again, as I said, all of the muscles are involved in all of these movements. So if we have a look at this red one here, the red one is supraspinatus, then we've got infraspinatus, then we've got teres minor, and then we've got subscapularis. So the rotator cuff muscles are SITS, SITS, Okay, so supraspinatus, infraspinatus. Obviously we haven't looked at these ones yet, but just to let you know what these things mean. Teres minor and then subscapularis, and then these are the movements some of the main movements that they do. Okay, so we've got abduction for supraspinatus, infraspinatus, external rotation, teres minor, external rotation, subscapularis, internal rotation. It's very, very simplified. Okay, I have to tell you that. They are all involved in all of those actions. But again, for exams, especially level 2, level 3 exams, those are the kind of things, those are the kind of questions that you're asked. So if you need a quick way to remember the actions, I mean, to be fair, if even if you just remember sits A, E, E, I, and you write that out for an exam, and you just do the movements, and you're like, right, okay, yeah, supraspinatus will bring about this movement, subscapularis will do this one, then you get you can then remember where they attach, because if you know what actions that they do, then they have to attach in certain places to bring about those actions. So it could be useful for especially, like I say, level 2, level 3 exams. Once you start getting level 4, level 5, you need a bit more nuance than that. Okay, so but it's handy to know from the off, I think. Let's just have a look at that again. So spine of the scapula, there's your acromion, superior to the spine, supraspinatus, in the fossa, so in the dip, in the shallow, underneath the acromion, and then onto the greater tubercle just there. Okay. And then from the side, so there's your humeral head. There's your acromion. You can see the subacromial space. Bursa usually around that area there, which we looked at last week. And then there's that abduction movement. But as I say, in a living body, everything helps. It just doesn't work on its own. Cool. All right, just make sure we've got no questions. All good. Right, so if you've got any questions about anything as we go, or you want some links to things or books or whatever, just give me a shout. And if I can't remember off the top of my head, then I'll pop it in our Facebook group. So this is the next one. So part of that sits, so SITS. So we've had supraspinatus. This is infra. It's in the infraspinous fossa this time. So there is a shallow, there's a dip on the back of the shoulder blade. Okay, so this is the posterior aspect of the scapula. There's your spine of the scapula. Supraspinatus was up here, so it was superior to the spine. This is infraspinatus. Lot bigger muscle, this one. Okay, so really broad contact on the shoulder blade. It literally just fills that space and then comes across as well onto the greater tubercle. So there we go, so greater tubercle of the humerus. But where supraspinatus attached to the top of it, so on that anterior portion, this one attaches more posteriorly. Okay, so it's right around the back. We've got lateral rotation or external rotation of the shoulder. It will also help with adduction, extending the shoulder, horizontal extension, so bringing the arm back as well. But basically, if you hold your arm out in front of you with a weight in it, all of your cuff muscles will engage. Yeah, so it's again, these are some of the kind of simplified movements that you may need to know for exams, but these are involved in everything. Okay, it's really, really hard to isolate these muscles. Let's have a look at this one. Oh, we'll do the next one as well, because this video is the two together. So let's do that one. Okay, so next one is teres minor. Now, I've put these two together because they are very close together. So if we have a look back, so there's an infraspinatus there. Okay, there's the infraspinous fossa. And then if we go forward one, there's your teres minor. Okay, so infraspinatus is literally just above it. And when you have a look at the specimen in a second, they look like the same muscle. You can just about make them out, so there is a separation between the two, but they pretty much attach to the same place as well. Okay, so infraspinatus just a little bit higher, teres minor just a tad bit lower, a lot smaller, teres minor, and then attaching onto the kind of lateral border of your shoulder blade, of your scapula. So the you've got that broad attachment point for infra, and then a smaller one there for teres minor. So we've got the superior lateral border of the scapula, so that area there, and then the greater tubercle of the humerus as your attachment points. And then again, exactly the same movements as your infraspinatus. Okay, so exactly the same. If I just move me out of the way. So these instructions here are for palpation. So to feel teres minor, you can lie someone prone, abduct their arm, and then resist lateral rotation, and that will engage that muscle. And if you've got your hands in the right place, then you'll be able to feel those muscles engage. Again, trying to differentiate that one from infraspinatus, bit dodgy. Depends on how well developed that person's shoulder is and how much body fat they've got. If you've got a bodybuilder, you'll probably be able to see it, no problem at all. But normal people, then usually no. Okay, you have a good idea that you're more likely to be on teres minor the higher up the scapula you go. Okay, so let's have a look at that one. Just get rid of those two. Hopefully this should be it. Yeah, perfect. So we've got the two together because they literally are right next to each other. So there's your bony anatomy again, picture you've just seen, and then there's infra. Let me just pause that there. And teres. So they look like one muscle, as I've put there, yeah? And so here's your shoulder blade, just behind. So there's the medial border. There's the inferior angle there, lateral border coming up this way. There's your humeral head. There's your acromion, spine of the scapula. Okay, so now we're inferior to the spine, so underneath it. That, and you can kind of work out the two. So can you see that kind of line of fascia there? It sort of, yeah, marks one from the other, but they both basically look the same. Okay, so we've got teres minor and infraspinatus on the back there. So teres minor a little bit lower than infra, and the attachment points, infraspinatus just above and teres minor just below. And then again, that's your greater tubercle just there. And then again, because of the orientation of those muscles, so where the fibers go, it makes sense that it will externally rotate the humerus. But again, if you hold your arm up with a weight in it, those muscles will engage. Yeah, so isometric flexion, isometric abduction, isometric horizontal flexion, whatever position you want to put your arm in, those cuff muscles will engage if you load in those positions. So that, and this is it's kind of it confuses people, I think, sometimes, but then actually it makes you very free, because if you need to rehab a shoulder, if you need to do exercises for a muscle, you don't, and they can't do abduction and they've hurt their supraspinatus, you think, well, what else am I going to do? It doesn't matter. As long as you isometrically engage those muscles in any position and find one that is not sore and they can tolerate the load, then just load it, okay? Because it will engage those muscles, and it will help to decrease their symptoms, and it will help to increase their tolerance to that to the movements that are sore. So if we have a look at this picture here, this is a side view of the socket, of the ball and socket. There's your coracoid, so this is towards the front here. There's your acromion. There's the spine of the scapula around the back. So this is posterior, this bit here, and this is anterior just here. So if we have a look at the glenoid fossa, so that's your socket of the ball and socket, then these are where the muscles attach. So that it's the SITS acronym again. So we've got supraspinatus at the top, infraspinatus posteriorly, just underneath that teres minor, and then towards the front subscapularis. Yeah, and you can see how all of those tendons of those muscles all merge into the capsule that surround the shoulder, which is what we saw, I think it was last week or the week before. Okay, so they all merge in together and form this capsule. So let's have a look at this. So there's this is a bit of a tour. Let me just go back a sec. Here we go. Okay, so there's the external rotation of teres minor and infra, and then here we go. So there's subscapularis at the front, supraspinatus at the top, infraspinatus, teres minor, all wrapping around, but look at how it's all merged in. Yeah, so there's your sits. Oh, just go back. Just play that through again and just hopefully pause it at the right point. There we go. So there's your sits. Okay, so supraspinatus at the top, infraspinatus, then your teres minor, and then your subscapularis at the front. But again, like I was saying, it's not like the picture, it's not like this model. Yeah, so this model has got, right, this attaches here and then this attaches here, and you can lift it off, and there's a blue bit underneath to show you where it attaches onto. They all merge into one, okay, and they all just completely surround that shoulder. And another thing, because obviously Adam Meekins is a physio, specialises in shoulders, so you get a lot of information from him, which is really good, and his analogies are really good. And he describes the cuff like a blanket, because I think people in their head, they imagine it like cords, and if there's a tear in a cord, like a rope, that would seem catastrophic, because it's like the rope's broken. Yeah, but if there's a tear in the cuff, so if there is a tear in one of the rotator cuff, it's more like a tear in a blanket than a tear in a cord, because it's all joined together. And then that's less fearful for people, because if they think that a rope has snapped, then they won't be able to do that movement. But if there's a bit of a hole in a blanket, everything else is going to contribute. So it kind of makes sense, a bit more sense, I think, than explaining things like cords. So there's the cuff all the way around. And again, you can't see, I mean, if I just go back there again, you can't see where the different attachment points are. Look at it. It's just all the same, all the way around. Yeah, all the way around there. Maybe infra teres, you could say, but look at that's all just merged into one. Yeah, so it all looks exactly the same. And if you want to show these videos to patients, if they can stomach it, then I think it's useful to show them the inside of their shoulder, what it looks like, so that because they'll have an image in their head of what it is and how it's been described by someone, and what they've seen on the internet. And then if you can show them something like that, then it really does help them understand it a bit better. Cool. So last one for your rotator cuff, probably one of my favorite ones, this one, subscapularis. Massive muscle. It's got lots of it's multi-pennate, so it's got lots of bundles of muscles all running along each other. And when you do imaging of a muscle, you can have a look at it at a couple of views. So you can have a look along the muscle, and you'll see the fiber direction. You can also have a look at it across the muscle, like a cross-sectional view. And in a muscle like rectus femoris, for example, it's just one straight muscle. In subscapularis, because it's multi-pennate, you've got these bands of fibers running alongside each other, and they look like tiger stripes. So when you scan a subscapularis, it looks like tiger stripes attaching into the shoulder, and it's very, very distinct. Okay, so it's there aren't many muscles like this one. And if we have a look at it, it's kind of hard to get your head around where it is. Let's just go back to the main screen again. Excuse me. So this is the front of your shoulder here. So this is subscapularis just here. There's your coracoid process. There's your clavicle. And then if I just take that off there, so that's where your subscapularis will go in that space there. But in a body, the rib cage is here. Okay, so it's facing the back of your rib cage. I think that's the hardest thing to get your head around. And then if I can connect that back in again, there we go. So the muscle comes around. You can see, well, even on the model, can you see the different, how they've done the different fiber directions? Yeah, so all coming along. So all these different bands of muscle coming along, and then they insert onto the inside of your shoulder, just here. But then can you see that there? That bit there is the transverse humeral ligament, and then that's your bicep tendon just there. And that subscapularis, it doesn't just stop where the blue bit is there, okay? Again, it's continuous and it merges into this transverse humeral ligament just here. So it'll come across all the way across there. Yeah, and again, it will merge into that whole region. So that's where your subscapularis will attach onto the inside part of your shoulder, basically. Okay, so if you know how to palpate the bicipital groove, so if you just pump the chair up a little bit, if you rotate your arm in and out, so externally and internally, have a feel of the front of your shoulder, and then you should feel some bumps as you rotate, and then there'll be a dip in the middle, and then that dip is where the bicep tendon will come through, and then just to inside of that, that's where your lesser tubercle is, and that's where your subscapularis will attach onto. So that point there. Okay, and then on the outside of that is your greater tubercle, where supraspinatus and then infraspinatus, teres minor around the back, they'll attach onto there. Okay, so they're all really, really close to each other. So yeah, if we go, so that hopefully makes this picture make a bit more sense, because it seems a bit distorted, this picture. There's your coracoid process. There's the medial border of the scapula just behind the ribs. Lateral border of the scapula just there. So the subscapularis will fill that space, and it's called the subscapular fossa again. So it's that dip or hollow in the bone, and then it will come across onto here, which is the lesser tubercle, and then merge into that transverse humeral ligament and come across the bicep tendon. Okay, so it'll come across here. So again, all really, really close together. It's the largest of the rotator cuff muscles, see down here. Stabilizes during majority of powerful movements, but again, all of them do. Okay, but this one is a powerful internal rotator, specifically because of the fiber direction. But if you think about it, I mean, this makes sense with all of these rotator cuff muscles. These muscles are attached to a floating bone, okay? So the scapula doesn't attach to anything. So if I wanted to internally rotate my arm with force, then my shoulder blade needs to be fixed for me to be able to do that. So all of the muscles that attach onto the shoulder blade have to keep my shoulder blade in position so that my subscapularis can then rotate that, or do that movement. Okay, do that internal rotation movement. So it just doesn't make sense that you can isolate structures in specific areas. You would have to have trapezius, rhomboids, levator scapula, lats kick in, trapezius kick in. Everything will have to maintain the position of that shoulder blade so that you can bring about internal rotation. Yeah, because if the shoulder blade moves, then subscapularis isn't going to be able to do its job, because it's just not stable. Okay, so again, they all have to work together. Right, let's have a look at this one. So this is subscapularis. Excuse me. So there's your bony landmarks. That's the picture we've just seen. And then here's the other side. So there's infraspinatus and teres minor, acromion, coracoid, and then there's your subscapularis. Massive. Look at that. Just covers that whole space. Really broad attachment. and then there's your attachment point on the lesser tubercle just there. So really, really huge muscle. And again, if you just go by fiber direction, then it will internally rotate your glenohumeral joint. So there's teres minor, infraspinatus around the back, acromion, humeral head, coracoid just there, huge subscapularis. There's your attachment point, so really broad on the front of the shoulder blade, and then onto that lesser tubercle just there. And then internal rotation, amongst other things. Okay, cool, perfect. There we go. And then, yeah, so this may be useful, excuse me, like I said, for level 2, level 3 exams, it will be useful because you will usually get questions on this. And I think this is where a lot of the confusion comes in, is because at that level, this is what is taught. But then unless you are told that it's not as simple as this, but you need to know this to get you on the ladder to learning how things work, then that's what you believe is all it does. Okay, so that's why I'm here to tell you that's not all it does, but this is a good way of remembering things for your level 2, level 3 exams. So supraspinatus, infraspinatus, teres minor, subscapularis, abduction, external rotation, internal rotation as a basic. Okay, so that's useful. But then look, we've also got an addendum here, plus adduction, extension, and horizontal extension. Yeah, plus every other blooming movement that the shoulder does. So it's a useful guide for those lower exams. But if you're doing a degree or doing level 4, level 5, then yeah, you need to have a bit more knowledge than this, I'm afraid. Sorry. And then this was the image that I showed you on the video. So we've got the glenoid fossa, which is your socket of the ball and socket. Look at all the ligaments around. So these were the ligaments that we saw last week. So the glenohumeral ligaments. Then you've got your subscapularis tendon. You've got your supraspinatus, infraspinatus. So there's supra there, infra just there, teres minor just there, and then they all merge into the capsule, the ligamentous structure of the capsule, to maintain the position of that humeral head. Okay. There's the bursa just above. There's the acromion just there. So this nasty subacromial space. Okay. Which isn't so bad. All right. I think sometimes surgery is useful. Yeah. There is a point when it has to be done, like when we were talking about the AC joint separations. Yeah, you're not going to heal those on your own. You could survive with certain. It depends what you want to do. You could survive without them being attached, but your life wouldn't be very nice to live if you wanted to keep active and have full range of motion of your arm still. So surgery there is really useful. But sometimes with these kind of impingement syndromes that we've been talking about for years, sometimes it's not very useful, and actually rehab is, and we just need to give people some good information about the anatomy, our understanding now of the changes in anatomy as we age, and the fact that those things that we see on scans, they are often blamed for pain, and then they're not the problem. So we need to give people that information too. Just before we go, because we're just coming up to time, I did my ultrasound exams down in Bournemouth, and we had a guy in clinic who had a problem with one shoulder, but I couldn't remember which one it was. Say it's his left shoulder, really painful. Scanned it, no issues. We always scan the other one as well, just to check, see if there's any differences. And then the one that we scanned, that we checked, he'd completely torn his bicep tendon. There was no bicep tendon, and that's usually one of the first things that we check. So we scanned it. That's a bit weird. Have you ever had any problems with this shoulder? No. He'd never noticed that he'd torn it. He'd never had any movement changes. He'd lived his life normally, and this would have happened a long time ago, because as we scanned down, the bicep was still there, but it was all scrunched up and it was just a bit of a fatty mess. But it was his other shoulder that was sore, and there was nothing there on the scan, but on the other side, no pain whatsoever, and he completely ruptured his bicep tendon. So that's a good story to show that the scans always don't always give you the bigger picture with things. Okay, so there we go. Rotator cuff in 45 minutes. Hopefully that was useful. We are going on to next week, the brachial plexus. Might take a couple of weeks, okay? And if you've never looked at it before, then have a bit of a look on the internet. I've done some previous videos on the brachial plexus, and each time I've added a bit more information on. So we'll do the next version next week, okay? But yeah, hopefully that was useful for you, and you now understand where all the rotator cuffs go and what they do. And if you deal with patients, then it's helpful. If you deal with exercise, then you got a few tips there as well. Cool. I will see you next week, Monday, 10 o'clock. See you then.